Hello everyone, this is Amr Asker, the founder of Asker Orthodontics. Welcome back to Cases Series. Today we have a very exciting case because the patient came to the clinic with midline diastema, and I noticed here a deep bite anteriorly and the midline shift between the upper and lower incisors. The right side we have scissor bite on second premolar and a little space for canine in this side and a second premolar space in the upper left side. Here we have like 2 mm space for the upper canine with a space between lateral and central and midline diastema and more space for second premolar. After I looked closely, I found that the patient has bulging here in the left side. And if you noticed here, the upper central incisor labial surface is obvious from occlusal view. That means that this central incisor is retroclined, so we can't see the palatal surface of that teeth. And in the lower incisor here, you can see also the labial surface of lower incisors. That means these teeth are retroclined. Two rotated lower canines and retained second molar primary teeth here. So now we need also to correct this midline shift. That's obvious 3 mm midline shift for that patient. So little space for the upper canine, midline shift and bulging here that indicates impaction palatally. Extraoral photos here, we can notice the midline shift in the upper arch and the retroclined upper incisors. In the profile view, the relation between lips upper and lower with the E-line is almost negatively to the E-line more than normal. So after requesting panoramic X-ray, I noticed the impacted upper cuspid and second premolar. The crown of the upper cuspid is overlapping the root of the lateral incisor, and here we have a missing second premolar with retained primary molar. I requested a CBCT from the patient, and in the CBCT cut for the upper canine, I noticed here there's a soft tissue impaction in the cuspid and also soft tissue impaction in the premolar. This is the cut of second premolar with the impaction is only soft tissue. In this volumetric X-ray, we have a normal skeletal relation anteroposteriorly and retroclined upper central and lower central incisors. So the treatment plan was as follows. Gaining space method will be proclining upper and lower incisor that's supporting the lips and the relation between the lips and the E-line, and also will gain space in the upper and lower arch. So I started the upper arch with wire 12 night tie. I bonded rough braces and also I adjusted the midline of the arch wire with the mid-sagittal plane to aid in aligning and leveling and correcting the midline. The scissor bite will be corrected by the arch wire between first and second premolar here and first molar, so the second premolar will move like a little bit 1 mm palatally. The rotational effect on the first premolar will give us space and the proclination will give us space. Every 1 month I change the arch wire to 14, 16, 18 and then 16 by 22 night tie, and after that I bought rectangular steel wire. After putting rectangular steel wire, I bought open coil. The open coil will close anterior spaces, will procline upper incisor, and that will aid in midline correction. And also I bought dead coil here passively to maintain the second premolar space, and I will only utilize 1 to 2 mm here from E space, the difference between the E and second premolar. After activating the open coil for 3 to 4 months, I gain almost all space for the upper canine. And now it's time to expose the cuspid, expose the premolar. I bonded eyelet on the cuspid and eyelet on second premolar. Here I used piggyback mechanics as anchorage buccolingually. So we can notice rectangular steel wire, open coil passive, night tie 12 wire, ligature wire traction for the 12 wire to avoid the bending angle to be more than 30 degrees, and here the wire inserted directly in the eyelet on the second premolar. So every 1 month I will activate the ligature wire, the second premolar moved buccally and the canine moved labially. I activated 2 to 3 millimeter the ligature wire for the 12 wire. After 1 month, the canine moved more labial, and now it's time to rebone the eyelid, make gingivectomy, to bond the braces more gingivally to allow extrusion of the cuspid. So I returned it back to single wire 12 nighti. I inserted the wire in all teeth, and the wire now will extrude the canine and allow a rotational effect in the upper canine. So wire 12 in all upper incisors after gaining space and after moving the canine labially. At the same time, I bonded lower incisors, and I need to raise the bite. So I raised the bite with Fuji on the palatal cuspis of upper molars to allow the upper teeth not hitting the lower incisor area. The gaining space method for the lower incisor is teeth proclination. So I put figure 8 otis on both canines to allow rotational effect on both canines, and that canines will move the lower lateral and incisors more labially, that will gain space by proclination. So now the lateral will be moved labially, that will correct the overjet. Don't forget the bite raising palatal cuspis of upper first premolar first molars bilaterally, and I will decrease the height of cusps gradually till reaching the normal bite. The canine almost in its place, and now it's time to close any residual spaces by power chain. After changing the arch wire every 1 month, now I reached rectangular arch wire in the lower arch. Almost the teeth now is aligned. The teeth proclination happened, and now you can see the lingual surface as normal in the lower incisors. I lift the primary molar here to act as a space maintainer till the implant time, till the patient reach like 18 years old for implant. So this is step by step for the case. Leveling and alignment firstly, opening space for the cuspid, piggyback technique, moving the canine forward, inserting the wire 12 in all teeth, closing any residual spaces by power chain, and after leveling and alignment we should remove the bite turbo. So the midline is almost on, and this is pre-operative photo and post-operative photo. The midline is correcting, the teeth retroclination that found in previously here is corrected, and I achieved canine relation class 1. There is no scissor bite on the second premolar, and the remained E is here. Class 1 also on the left side, canine, premolars and molars. The deep bite was almost corrected, and this is the pre and operative occlusal view. Here we can notice the midline shift, and here after correction. Here you can notice the retroclined upper incisors and labial surface is almost appeared. Here after correcting the teeth torque and after protruding the upper incisors, the palatal surface now is obvious. And here is also the lower retroclined lower incisors, and here is after reaching the normal torque of lower incisors. The smiling photo for the patient is good, and the profile photo is the patient. There is no retroclined upper incisors anymore. And this is a pre-operative panoramic X-ray with impaction, and this is a post-operative panoramic X-ray after moving the root of the canine medially and the crown of the canine distally, and I fixed retainer on the lower arch and still remained primary molar. So this is a case of impaction. Don't forget the piggyback in your impaction cases to give anchorage backlingually, and sometimes to give anchorage up and down in labial impaction. The main wire is rectangular steel, and the second wire is 12 that is ligated to the impacted tooth by ligature wire or gold chain. Stay tuned for more episodes, and if you like our cases discussion, you can share and subscribe for our channel. See you.